And hello, everyone. Great to see you. You've made it. Congratulations. Today we have none other than Professor Mustefa here again to help us conclude our learning journey. And thank you for everyone who did the final exam. We got 437 responses. So, you guys are a mighty group. That's a lot of learning that's happening, and we saw big improvements compared to the beginning of the course. So I'm not sure if I'm going to steal thunder, but Emily, maybe I'll share the statistics just to um, give people a sense of how they did, because you should all see your scores. And also just to kind of cue Professor Mustefa about what the group's performance was. The average score in the beginning was 5.8 out of 13, which is about a 44%. Now afterwards, the average score rose to 7.6 out of 12, which is a 64%. So this is a hard test. We weren't expecting people to get 100%, but we saw a 20% increase. So that's really good. But we're going to go over those answers today to make sure that you understand all the concepts and that, we're answering all the questions. So with that, I'll give the floor to Professor Mustefa, and I'll be here to help take any questions in the chat. Feel free to write. Thank you.
Thank you, Dr. Lee. How you doing, sir?
Good, great to see you.
Yes, sir. Good to see you. All right, let me try to share my slide first. Let's see. Morning again. Just like, Emily and Dr. Lee said, power to you for making it all the way to the end. Okay, today we're going to have a review for the final. And before that, I'm going to talk about patient care. Let me get to those goals for today, actually. Yeah, so we're going to start with patient care. Then we're going to review the final and a couple of slides on the mission of RTT team and transition to MRT. So, all right, before we've been talking about all the technical skill that we need to have for this, all the machine. But at the end of the day, the center of this attention is the patient. Whatever we do is for our patient. So when I think of patient care, I think of one word. If I have to explain patient care with one word only, that's it, empathy. One word. And anybody knows the meaning of empathy? Anybody willing to talk? Anyone? You could open up your mic.
It's about mercy, kind of mercy, sorry.
Go ahead, what do you say?
Sharing in the patient's pain, like you show them that you really feel for them and you're ready to help.
That's right. That's right, That's
Hello?
it. Hello,
empathy simply means putting yourself in the shoe of the patient.
Through that. So the ability to understand and share the feeling of one another. The key is, when we have machine goes down, what we're behind, do we still keep that, definition? Or do we get frustrated? So I found this, there's a doctor, Dr. Hannah Reese, she's a Harvard professor. She took this acronym of empathy, you can see that, the EMPATHY, and she came up with these words, the seven keys of empathy. And the first one is eye contact. It's, the first indication of that we've been noticed or we've been seen is the eye contact, people looking at us. We all want to be noticed, especially, when a patient comes in, they're tired, they're weak. Let me fix my camera, I think. All right. So you see, the eye contact is the key. And the second one is muscle of facial expression. Sorry, everybody, there's my camera dropping.
You're okay. We still see you.
Dr. Ben, I think I need to do some technical training. The muscle, you know, so facial expression, it makes a big difference. Even sometimes we get frustrated, but you know, let's avoid to show to our patient, you know, are we smiling? Are we frowning? The third one is posture. How do we talk to them when we talk to them? You know, sometimes, you know, we probably bring our hands together, clasp them and stuff like that. We'd be defensive. They could read this. Or sometimes you have a patient on a wheelchair. How do you talk to them? Do we come down to their level? Do we sit down on a chair? And the effect, are we reading their emotion? What kind of effect that we have on them? Sorry again, people. Space right now. And number 5 is tone of voice. How do you talk to them? See, right now we lecture and we're sitting here, we calm now, but when in real life, you know, when we have machine going down, we're behind a prostate patient, you know, blood is not filling up. How's our tone of voice? Because they read that. What we have to understand is we get inconvenience because we probably be late going home in case, you know, the patient is behind or patient is like, you know, it's not setting up well. You have to take another imaging, but you have to understand these are the people fighting for their life. So how's our tone of voice? Then comes the H is hitting the whole person. Are we just, you know, listening to them just for them to let out their frustration, or are actually understanding the context where they're coming from? And finally, the response. How do you respond to that patient? So I love this actually. You know, I was looking for, I found this, you know, when I was looking at this is pretty good. So next time, you know, when you have a patient, when you get frustrated, I want you to go, you know, think yourself, go through these 7 letters and see, you know, how you respond to that patient. Basically, you know, if we check ourselves, you know, if we improve ourselves, you know, that means this, I mean, this, we are in the business of empathy. Simple as that. We chose this field. There's no any other way. With this, I'm going to continue with the patient care. Radiation therapy somehow is unique because the therapist sees them every day. Even the doctor only sees them once a week, but we're the one who sees them every day. So whatever experience they have with us is what you call it, it's going to make it or break it. Some patient may give up, not because of the side effect of the treatment, not because of the tiredness and the fatigue. No, because some patients give up because of the therapist, or it could be the nurse, or it could be the doctor. So the question is, how do we do that? Our goal is, you know, to eradicate tumor, but if you know, the experience is not good, it make it difficult for the healing joint. See, we want to take them from this to this. We go back again. You know, we don't want them at this point. Because you understand, you know, this for the patient, this is a new thing for them. They've never been to this area. First of all, you know, cancer is heavy on them. Then they want to come into a new territory that they've never been before. There's chemo, there's radiation, you know, all of it like, you know, has so much side effect to their body. They're all nervous. You know, people tell them, you know, probably they've been searching about what radiation is. They probably got the wrong information online. They talk to people, they probably give them the wrong information. Now they come and we don't show them the right way to treat them. They're going to be nervous, but, you know, we want them happy. We want them, even though it's tough experience, we want to make it like, you know, a happy experience for them by communicating. An informed patient is comfortable and calm. We have to tell them from the beginning, either from simulation all the way to the treatment. All the way to treatment, doesn't matter. For example, they have 30 fractions. we have to keep communicating, because every day they may come with a new side effect. They may feel tired. Like I said, I spoke to this before. These are hurting financially, spiritually, mentally, they're hurting. But you have to understand, in some culture, actually, they think that still cancer is contagious, and they get abandoned by a family. Some of them, they sell the land. Some of them, they sell whatever they have to come to for treatment. Some walk miles of miles to get to a center. And the good, we got to talk to our patient. But let's take a head and neck patient who stands with bolus. We tell them, make sure that, sir or ma'am, we're not going to tell you that we're going to forget, but you know what? In case we forget to give you the stent or the bolus, remind us. Just communication, simple communication, make it easy. Instead of, oh man, I forgot to put that bolus. Teaching is the key. Introduce ourselves, that's the key, the first thing. And let's tell them what's going to be during the simulation, what we're going to do. Especially when you're making those masks. This hat is wet. So, it's for the first time experience, and let's tell them what's going to happen. That way, they don't freak out. And how long it's going to take? Will it hurt? Once, communication is the key. But like I said, go back to those 7 letters of empathy and make sure that the way we communicate, our posture, our facial expression. And always keep that eye contact. From culture to culture, eye contact changes. But, we all have different kind of eye gaze. Just apply that, wherever we are. How long will it take? What happened during the appointment? The imaging, those imaging panel, they come out on the side of the patient. They're laying down on top of this table. They're scared because that table is, how small that table is. And on top of that, when they see that this big machine's coming out, they're probably going to be freaked out. So tell them what's going to happen. Let's tell them that the machine is going to move, especially if there's couch kick on the. Get them prepared. And tell them, like, at this point, the machine is going to do this. At this point, we're going to take the x-rays, the imaging, CBCT. When you hear the sound, that means we are starting a treatment. Again, it depends what we treat. If they have to change clothes, staying still during the treatment, and keeping those marks that make sure that you don't lose them. And if the patient probably laying down, we tell them not to move, and they're about to cough and sneeze. We have to explain that to them, what they do if they have to sneeze, what they have to do if they have to cough, or in case they don't feel comfortable. Like, we have to make them like a family, because we're going to see them for a week, 2 weeks, 3 weeks, 6 weeks. Again, any kind of instruction on prescription, communicate with them. Some patients probably were told by the doctor or by the nurse, to have that bladder prep and bowel prep, but they may forget. So before they come in, communicate with the patient, call the patient, tell them that, okay, don't forget to make sure that you have, full bladder or empty bladder, empty rectum. Breathing instruction during when we do gating. Don't tell them, let's not tell them when they are on table. Let's tell them before we start, this is going to happen. After we take this x-ray, we're going to tell you, before we take this, after we set you up, we'll tell you to hold this. For how long? You got to tell them. Have that practice, actually. Say them how long they're going to hold it. Can they hold 10 seconds or 15 seconds or 20 seconds? Yeah, what's going to happen, if they breathe during the, people, they're new to this. They are new. They're nervous, they're confused. So communication, again, communication is the key. Okay, tell the patient, what you do before we do it. This is okay, like I said again, when you move them, You can tell them that I'm going to use to the right. I'm going to the left. Don't move, please. We'll make you move. When you please, the bullets, sometimes bullets they get cold. It may be cold. I'm gonna place this on your neck. And if you have to see, area, because sometimes we have to treat those close to the private parts. In any area you open up, if the patient's covered, tell them that I'm going to uncover you. Another thing, we get busy when we look at the first day, we look at our paper chart or any paper we have, let's not put it on top of the patient. Like I said, it's not like they're not a table. So it's like makes them like a whole person. Let's make that experience a comfortable experience. And once we do that, after a couple of days, they know exactly what's going on. But we have to instruct them. We have to show them. It has to be with compassion. Always has to be, you always need to show that empathy. You need to understand this. If a patient don't, one of the question on the exam, I'll get to it when I get there, but some of the stuff, the problem happens if the patient got not treated well by a therapist or nurse or doctor, they give up, they don't come. Then we have what? They go interrupt the treatment and you have repopulation. That's what we're trying to avoid. Actually, we are making more damage now if they don't come out, if they don't come back.
Excuse me, may I say something?
Right.
I think it's very important, like example, I have to understand the patient should he needs or she needs from us a very important, a polite, we have to be polite, we have to be humans. And if I will see my patient there on the table, I would like to share with him, like, I am friendly, I understand him, and I can be that patient in one day. And it's very, very important. I think we have to think like, if I am the patient, how I will like to be treated. Now, the same like everyone from my family, like sister, brother, mother, everything. Mercy, compassion, everything. Thank you. That was my idea.
Thank you so much. Thank you so much.
Thank you
so
too.
compassion. Yeah. Tomorrow, who knows? Us, our family member will be on that table. This patient has family. They have spouses. They have children. They have dads. Let's not forget, yes, patient have identification number. But they're not like, device and assembly line and factory, because, we have to go beyond that. This is a human being that we're dealing with who has feelings. They hurt them. Like I said last time I spoke there, one of my patients, I was treating a head and neck patient. We were talking, and he told me, you know what, Mustafa? He goes, what? I cannot wait till I taste the taste of ice cream. That's what he told me. He wants to taste ice cream. Everything he eats right now tastes like a cardboard. He cannot wait, to heal and go back, taste ice cream. He just craving for vanilla ice cream. Think about it, man. We take this for granted. We just get out of here and grab us like ice cream, or, we have anything. We enjoy that. Let's not forget that. Again, let's put that compassion and empathy to this patient. They are hurting. They're fighting for their life. Once we do that, I'm telling you, once we do that empathy, we're going to learn this, the key of being successful in radiation therapy, in any kind of a medical field, actually, the empathy. Once we understand that, will force us to learn something, how we're going to better our patient's life. Thank you so much. That was good. Like I said earlier, the patient who's informed is comfortable and calm. If they're comfortable, they're calm, they don't move, our work gets easier. You take the X-ray. Sometimes you see, you take the X-ray and you make a shift, and post-shift, you take the X-ray. Still, you need some more shift because they moved. Let's give them all the information they need. Then they be comfortable. When they come home, they calm. That's what we want. And again, let them participate on their own care. Okay. Now we go into the big one. Here we go. The dose of radiation that's received. Give me a second here again. Did I do that? All right.
Sneak peek.
Okay. The dose of radiation that's received inside a patient's body depends on the density of tissues seen on CT simulation scans. This is because A, the density of tissue affects the beam's depth beneath skin surface. B, the density of tissue affects the energy of the beam. C, the density of tissue affects the absorption of beam by the tissues. D, the density of tissue affects whether charged or uncharged particle interaction occur. Anyone?
So looking at the chat, it looks like some participants are saying C.
Okay. C, can anybody explain this to me? That's the right answer. Anybody?
Hello.
Hello, go ahead.
Well, for me, after the review, I actually choose A. That's the density of the tissues affect the beam's depth beneath the skin surface. But the correct answer seems to be density of the tissue affects the absorption of the beam by the tissues. It's more or less looking like the same thing beneath
Okay,
the
so
skin surface.
yeah, you know, I was looking at that. The answer is C, but it would be better to have like a clearer. I see why you chose A, but you know, now when we look at the density of the tissue affect the beam depth. Now, whatever tissue you put, okay, are you going to change the depth of the beam? Like you have a beam coming, all right. Let's say somebody's let's say let's take about somebody we measure. Let me see. For example, okay, let's say the body here is let's say 17 cm, okay? That's 17 cm, like, you know, anterior to posterior. Then you have 20 cm again. Will you change the beam depth will change? Whether you, for example, let's say 17 cm, let's say the beam depth is going to go 3 cm. It's going to start at 14, yeah? But if it's 20, it's going to stop on 17. So I don't think you're going to change the beam depth. The beam depth is not going to change. So you're going to be like the same. You're going to be down. You're going down to 3 cm, no matter what it is, whether it is you know, the density is big or small. You see what I'm saying? I'm talking about A right now. Do you understand what I'm trying to say here?
Yeah, I get you.
Okay, all right. So that's why B, the density of the tissue affects the energy of the beam. You know, it's not going to affect it. The energy is going to stay the same anyway, no matter what. The density of the tissue affects whether charged or uncharged. This one actually is not going to affect anything. You know, the closed answer is C. But I see why you picked the A though. Anybody has a question on this one? Because, you know, based on the density, the absorption is going to change. Everybody's good? Should I continue? Or anybody have something to say? All right, let's go to the second question. All right, anybody? Interruption and delays in completion of treatment are dangerous due to tumor repair, redistribution, reoxygenation, or repopulation.
Repopulation.
All right.
Right off the
Tumor
bat.
My name is Cornelia.
Thank you for it. All right, let's go. Dr. Lee, is there
Yeah, where it looks like lots of D's in the chat. some other
Okay.
answers too, so maybe it's good to talk about this one.
Okay. Actually, earlier I was saying that you remember we were talking about we don't want patient to not to interruption. Like I said, some patients just interrupt because they don't like the environment they're coming, not because of the side effect, not they're taking chemo, they're taking radiation therapy, they're taking other drugs for pain, but they're still willing to come. But if they don't feel that patient care, if they don't feel that empathy, they're going to interrupt that. That delay, what's going to create is going to create the repopulation of the tumor cells. So interruption and delay. So that's why we want to make sure that they finish the course of the treatment. This is like repair, and those are like the character of this tumor happening in reoxygenation. But when we treat, so when we say repopulation, describes when tumors are grow and divide between fractions, but repair and distribution and excision that occur, but you know what? They don't happen because of the delay. So again, let's remember this. It's not good for patient to delay treatment or interrupt treatment. So we have to make sure that they experience so good so they finish their course of treatment. The answer is population. Anything you want to add here, Dr. Lee?
Yeah, so one person asked, why not C? Why not reoxygenation? And I was just going to say that it's true that if you wait, you'll give more chance for reoxygenation. But the reason that the oxygen is important is not so much for the cancer, it's more for us doing the treatment. We want the oxygen to be there so that the radiation can be effective. If you radiate something and there's no oxygen, no blood, nothing there, then the radiation's not going to be very effective. So reoxygenation is just one of the reasons why we do wait a little bit after doing the treatment so that there can be more oxygen there the next time we do the treatment.
Thank you, Dr. Lee. All right, based on the figure, approximately how much dose does the skin receive if the midline is treated to 70 gray with cobalt 1.25 megavoltage?
84 gray.
All right, can you explain that to me?
84 gray?
Yeah, do you want to explain why it's 84 gray? The answer is 84 gray, that's right.
Yes, because the 70 gray multiplied by 1.2.
Yeah, okay. Why you chose 1.2?
The maximum dose of the cobalt 16.
Yeah, on that, because the skin surface, we're looking at the midline is right here, and it says the skin, yeah, okay.
Yeah.
So,
yes.
It's 84 centigrade, like you said, it's 1.2 times 70, but when you look at the code, let's take it right here. This is the midline, and you come right here, and the skin surface is getting the maximum. So that's why. Anybody has a question here? So if you go like, for example, if you go to 4 MV, it's going to be 110, so 1.1, and the 10 MV is right here, 100, so it's going to be times 1.
Hello.
Go ahead.
Hello.
Yeah, go ahead. Yes.
Yes, hello.
Yeah, I can hear you.
Hi, Martin. We can hear you.
I think I would also like to bring it. We should also talk about the Dmax of these different energies.
Mm-hmm.
So we know that the Dmax for the cobalt is 0.5, and that's where its max energy is deposited.
Yeah, what do you say? I don't understand. Go ahead. One more time.
Basically, the peak of each.
I was talking about that we should also mention about the Dmax of the different energies.
Yeah, so with
I think
the cobalt,
my connection is not.
No, yeah, we hear you, Martin. So he says we should talk about the Dmax of the different energies and where that is along the depth. So for
Oh
the
yeah,
cobalt, we see that right here.
thank you for marking it.
And then that's just pretty close to the surface, right intersects down here.
Okay, I got it.
Whereas for a 10 MV, looks like it's peaking right here, and then that's happening later on as it goes into the body. Great, thanks.
Thank you, Dr. D. Number 4, according to the DBH, how much of the spinal cord is received 500 centigrade dose? A couple of minutes to answer. Okay, so we look at this as our spinal cord is the orange one right here, and if you trace it back or even protein, so here you go right here, it's 500, bring that right here. And we come right here, close to 34, 35 right here. So the answer is C. Thank you, Dr. Lee. I don't know how to do this kind of stuff. Thank you so much. See? All right, thank you.
Yep.
Oh, this is cool.
Great.
All right, any question on this one? Which of the following is correct way to contour the parotid gland? Orange, light blue, dark blue, or pink?
Okay, contouring. Let's see. Looks like C is the popular answer.
All right, C is the proper answer. So you look at, started process right here. Usually, I know it's hard to see on a CT, but when the contours go parotid, they go to the styloid process right here. You have the mandible right there. Usually they do that. You just have to believe in that one. Dr. Lee, can you explain something? Can you add something on this one, please?
Yeah, so
C.
the parotid, C is correct. So that's great. And the problem with some of the other answers, maybe start there. So when we look at A and we look at B, they're not including the deep lobe of the parotid. So the deep lobe is going to be what goes inwards towards the styloid process. And Manoj Pillai, can you please keep your microphone mute? So you see A and B, I just drew what the deep lobe was that was missing. Very important to always remember to include the deep lobe of the parotid in the contours. Otherwise, your parotid is going to be fake. And your team is going to think that they're sparing the parotid when actually maybe they're hitting it. And so you get a false sense of security, and you could be causing more dry mouth and permanent dry mouth for the patient.
All right, which of the following statement is incorrect? The RTT must still confirm correct field placement and shape using the field light, even when MLC blocking is used in 2D or 3D treatment plans. Automatic treatment plan upload eliminates human error in entering machine parameter. Daily treatment parameter check are no longer necessary when using automatic treatment plan upload. IMR technique is more straightforward for the RTT to deliver. Time to answer.
Okay. Let's see, people are saying C. C looks like the popular answer.
All right, C is the answer. Anybody can tell me why A is not the answer? Okay, the arithmetic still confirm correct field placement and shaping the field light even when MLC blocking used in 2D and 3D treatment. Because this is correct, yeah, we have to check. Automatic treatment plan upload limits human error entering machine parameters. Yeah, that when we manually and automatically, the difference is you see it in IMRT, everything comes up, but we still need to check it though. I see, so that's why C is not the answer, because we still, no matter what, we still need to check our parameters, we check our images, we check our MLCs. IMRT is the most straightforward. They're straightforward to deliver than it's everything come automatic. Any question? Which of the following is the reason why patient immunization is important during radiation treatment? A, sophisticated treatment planning techniques allow for more accurate delivery of treatment. B, missing the tumor once or twice during a treatment course can reduce the planned dose by 10% or more. C, daily production of the planned treatment is essential treatment outcome. And D, patient immunization reduce patient anxiety and discomfort. Take your time. Basically, which was incorrect and we're talking about, not the reason.
Looks like some people are saying D.
Okay. Is there anything competing with D?
We have one C. We have a B.
Okay.
We have another B. So yeah, let's see what's the answer here.
Okay. The answer is D. So let's go. Sophisticated treatment planning technique allow for more accurate delivery. Yeah, because when you have like a cradle or mask, the patient stays still. And we do that during simulation, we mark them. So and make it, accurate delivery treatment. Missing a tumor once or twice during treatment course can reduce. Yeah, if you don't have a cradle, if they move, you're gonna have a chance of missing the hitting the tumor. Instead, probably end up hitting the organ at risk. And C, daily production of plant treatment is essential treatment for sure, because the production is reproducibility easy with a mask or a cradle. Patient immunization reduce patient anxiety and discomfort. It's not going to do it. Anxiety and discomfort is patient care again. We want to avoid that. Make sure we take care of our patient. Empathy again. Let's go back to that one. Number 8, methods to improve accuracy in treatment delivery accounting for interfraction variation include the following except respiratory gating, immobilization, pre-treatment protocol instruction for patient, like bowel, bladder prep, daily IGRT with CBCT pre-treatment imaging.
Looks like people are saying A.
Okay. Anybody wants to answer this? Why A? Because this is a good question, actually. Anybody want to answer this?
Let me give a try.
Yeah, go ahead.
Respiratory gating is for intra-fraction motion management. And the other 3 is for interfraction, between maybe fraction 1 and 2 on a day-to-day setup of the patient.
That's right. So like I said, the immobilization treatment protocol, daily IGRT is day-to-day change. If you say a patient right today, you're okay till you go tomorrow. So that's how but the respiratory, the gating is can make change while the patient laying down. If they're uncomfortable, or let's say if even the gating changes, it's going to change the treatment while they lay down on the table. So that's an interfraction. The interfraction versus intrafraction. So that's why. Anybody has a question with this? Let me click on the answer. Thank you for the answer. Anybody has a question? Anybody knows the difference between intrafraction? He explained those. Anybody has a question on that?
Interfraction is between days of treatment. Intrafraction is within that same minutes of treatment.
Thank you, everyone. Thank you, Dr. Lee. Number 9, target localization to a lung tumor can be achieved through the use of portal imaging, cone beam CT, KV, OBI imaging, stereoscopic imaging. Take your time.
Okay, people are pretty fast to answer. Looks like a lot of people are saying B.
Yeah, okay. Anybody want to answer where is cone beam CT? You know what, on this question though, I'll tell you what, from center to center it may change, especially for people, who never been exposed to cone beam CT, maybe may go, with the portal imaging, but in general, you want to, localize target, 3D, I mean, cone beam imaging give us the 3D of the image tumor. So the answer is C, but some people may answer different answer based on the center, what they have. But the answer is B though. Anybody has a question? Or anybody probably answer, portal image based on the exposure or KV OBI imaging. The last one is like, probably they use in Hollywood because it's like creating a. Go ahead.
Do you have a question, Umair? No.
So I have a question. So what's the KV on board imaging now? What's the use for? Best use for?
Which
use
one?
for? DC KV on board imaging.
Yeah,
What is it best use for?
KV still give you a 2D, yeah? So 2D imaging, and I mean, cone beam CT give you a soft tissue, especially if you like, your PTV or, let's say the doctor said, was set up, you probably put your KV for bony anatomy. Then if you want to see your GTV or PTV, the best way to do is, have that soft tissue. You see better with the cone beam CT, and plus you get to have that 3D orientation. You could do 3D.
Okay, so the major difference is just 3D.
That's 3D. One is 3D, and plus, for the if it is like you want to see your PTV, it's very hard to see it on your KV. You probably see soft tissue would be better to see it with the with cone beam CT. Dr. Lee, you want to add something to this?
No, I think you got it. Portal imaging is with MV. That's 2D. KV onboard imaging is with KV. That's 2D. Cone beam CT is with 3D.
Okay, which of the machines has these capabilities? Which of the Linux has these capabilities?
One more time, please. One more time.
Okay, I'm asking which of the Linux has these capabilities, the portal imaging capabilities and the rest?
Oh.
Like Halcyon.
Okay.
Halcyon has cone beam CT. Which called any 2100 or any Versa, from Versa or Varian or Electa, they have the capabilities.
Mm-hmm.
Right now, I think most machine comes with cone beam CT. I think it's a standard right now.
Mm-hmm.
Okay, I think we are using a variant which I think doesn't come with this cone beam. Comes with a portal imaging from this explanation.
Okay, so but do you guys have it has a KV imaging or not? It's only have the MV, the portal imaging MV, or does it have the KV?
It's MV, not KV.
Okay, yeah. So it has come. You have that KV because the cone beam CT work with kilo voltage. So if you don't have they mentioned that they don't have that KV imaging capability. So once they have KV imaging capability, they could commission the cone beam CT to it. If you don't have the KV, if it's only MV, so it's going to import that imaging.
Okay, so that means you could actually tweak this to, if your machine comes with a portal imaging, you can tweak it to a cone beam imaging.
Yeah, I mean,
what you're saying?
Machine can be upgraded, but you got to have so do I have any machine? Let me see.
Yeah, I can draw a picture.
Okay,
So
thank you.
if this is your LINAC, beam comes out here. You have your portal imaging here. The KB onboard imaging is like adding little arms on the side. One on the right side and one on the left side.
Amazing, Dr. Lee. This is like the best machine I've ever seen.
Yeah, I'm working on it. I'm gonna put it on sale soon. And
For
so
real.
now this guy can rotate around, and once you have your KV images there, as it rotates around, the KV is sending KV X-rays, and when that spins around, that can make the cone beam CT.
Okay.
Does that make sense, Victor?
Yeah, it does. It does. It does.
Okay, great.
It
Sir,
does.
thank you.
But there is also, during the course, there was this there was a saying that KV images gives more soft tissue details. Is that comparable to a cone beam?
Yeah, so the contrast is going to be the same, especially when it comes to especially the bony anatomy, you may have a contrast, but with the cone beam CT, see, cone beam CT moves in an arc. We see when you do a KV, for example, you do APN lateral, is you do like the gantry at 0, when you do gantry at 0. So let me see here, right here. Now see our gantry is 0 right here. So when you are like, if the image is coming to 270. And you have the imaging. This is what the source coming, and you take your X-ray, so you get your lateral image, and you turn this like 290, and this thing gonna come on top, and then your AP imaging, okay, on this KV imaging. But with cone beam CT, this thing moves just like an arc, so it's taking images while it's moving. When the gantry is moving like clockwise or counterclockwise, it's taking image the whole time. So it's creating that 3D image, okay. So it has a KV contrast, just like a CT. It's not as good as a regular CT, but you still can see. Somebody have a question?
Yes. Cone beam CT is do as a CT.
Sorry, what do you say?
Yes, I mean cone beam CT in linear accelerator at the same CT scan.
Yeah, that's true. Just like a CT scans, you have a different contrast to it, but you still can see your, area of interest. Any more question on this one?
Actually, I have a point to make.
Go ahead.
So actually, the person was talking about the KV, because the older version of Varian, that is like DBX and DHX, that doesn't come with the cone beam CT. So
yes,
in the previous center where I was working, so we have the same thing. Like we were going with the MV only. We don't have capability for KV imaging. Okay. So for IMRT also, we are going for the laterals and all, because with Varian, DBX and DHX, we don't have a capability of MV for the KV imaging. It's like CBCT. When you go for the higher version of Varian, I'm talking about Varian only because I don't know about any other machine. So it comes with the capability of doing KV imaging or CBCT. It's you can do it. With the lower version, you can't do.
Okay. Thank you so much. All right, let's go next one. All right, we got an imaging question. I like it. Still, we have the Varian. The machine. The machine's gone now. Okay, here you go.
Limited time only.
Nice, huh? Okay, here you go. Number 10. This is an overlay of an image taken on treatment. Blue is the APDRR. So you have blue as the DRR that came from the simulation. And the APDR, or on a treatment, taken on a treatment, blue, but the blue is the treatment actually, and the APDR is orange. So the orange is the one you got from simulation. How would you adjust the patient before proceeding with the treatment? No shift needed, just no movement since the skin marks are exactly aligned to the room laser. B, have the patient get up and start over with positioning. C, move the patient to the right, her right. D, move the patient to her left.
It looks like most answers are D, but some C.
All right, so the answer is D. That's right. You said some answer on C.
I mean,
Okay,
most
so
D, but yeah, let's go over it.
Okay, let's talk about that. Okay, no movement since the skin marks are exactly aligned. So, you know, we see that there's a shift, we need that. And for sure, that's why we start with our skin mark first. But, you know, patient could lose weight, patient could move a little bit. You know, the skin mark is not like, you know, we cannot depend. It get us to the ballpark, but, you know, we have to go outside and take X-ray imaging to make sure that we are aligned. So, A, you know, the answer. B, have this patient get up. You know, if you get up and start over again, basically what we're doing is we're giving them more dose anyway. We're going to X-ray again, and then they're off. Then, you know, again, what we're going to do? So B is not going to work, and taking too much time with the patient anyway, make them uncomfortable. All right. C, move the patient to her right. Now, look at it. Image is taken, and this is blue. This is the blue. So if you move the patient to her right, because, you know, remember that we patient lay down like that, this is the right side, and this is the left side. You able to see my mouse?
Yep.
Okay, because I cannot draw like Dr. Lee, so I need to work on that one. Okay, so here we go. This is the right and this is the left. So if we move the patient to the right, it's going to be offset more. She's going to be way off. So what we have to do, we have to move back to her left. Because see, this is DRR, so we have to match to our DRR. The orange is DRR. So basically what we have to do is move the patient to her left to align that. Is that okay? Everybody got it? Any question?
Mm-hmm.
All right, here you go. Number 11. When image matching on a CBCT, align to the bony anatomy because it's the most clearly visualized. Align to organ at risk nearest to the target because soft tissue is better visualized in CBCT. C, align everything with the PTV. D, align to the priority indicated by the MD.
Okay, it looks like we're a little split here.
Okay.
Some people are saying D, some people are saying A, some people are saying B, some people are saying C.
Right, we're going to talk about all of them then. Here we go. Answer is D. I should have waited though, okay. Align to the bony anatomy because the most clearly visualized. It could be, a case, you know, we probably see better, bone anatomy, probably we could see better than the soft tissue on the CBCT. Maybe the contrast. But, you know, that's why you have to read all the answers, okay? Align to the OR nearest to the target because some tissue are better visualized in CBCT. Align to the OR nearest to the target. I mean, our goal is not to align to OR. For sure, we need to avoid the OR, but our goal is, you know, to align to the target, yeah? But still, again, you need to read the whole answer before we answer it. Align everything with the PTV. Question is, now, do we follow prescription? Does the prescription says, you know, align to the PTV, or it said align to GTV, or align to CTV? We don't even know, yeah? So align to priority indicated by the MD. So we have to follow the prescription. That's what we have to do. The key is, well, sure, it's what works and stuff, but you know, all we got to do, the first thing we have to do is just follow the prescription, what the doctor want to see. The doctor may say that, you know, align to PTV. Maybe the doctor may say that, you know what, align to bony anatomy and shift to PTV, or check PTV may say that. So just follow the prescription. Dr. Lee, anything you want to add to this one?
Yeah, if I may, this is a great question, and the take-home message is when you're doing cone beam CT, you can't just be a robot and always align to the bones. You have to think, hey, what did the doctor want me to do here? And the doctor should write instructions. because like Mustefa was saying, maybe they specifically want you aligned to the GTV or the ITV or the PTV, or well, why isn't aligning to bony anatomy always fine? Well, bony anatomy is good in the era of 2D, but in the era of 3D, we want to be even more specific. Take a prostate, for instance. Prostate's like a little shaped like a walnut. It's kind of like an egg. It can roll around, it can move. If you just align to the bones, the prostate could be different from day to day. So and then, the rectum can be different, and the bladder can be different. So when you use cone beam CT, you get 3D image. Now you can be even more specific than the bones, and you can look specifically and align according to the prostate. Make sure that it looks like it's in a good spot with relation to the rectum. So this is the difference with 3D and cone beam CT. The bones is not good enough.
Thank you, sir.
Sorry, please, if I may take you back a little.
Yes, sir.
In situations where there are no instructions from your MD, what is your best bet? Wouldn't PTV be your best bet?
Yeah, if there's no instructions, or go ahead, Mustefa, you were going to say.
Go ahead, Dr. Lee. Go ahead.
Yeah, if there are no instructions, you may have to rely on your experience. In the past for this kind of case, what have the instructions been? If you've never ever had instructions before, yeah, like you want to make sure you're hitting the target. So that's really important. If you align to the bones, but then you see the target is really different from how it was on the sim, that's a red flag. You want to bring that up. Make sure they know, like, hey, like this doesn't look right. So and in some cases, aligning to the target means aligning to the bones. Let's say it's a spine metastases. Yeah, you want to make sure those vertebral columns look exactly matched in the area where you're doing the treatment. Does that answer your question, Victor?
Just like you said now, your PTV might be in the area of the bones. So how do you strike that compromise?
If your PTV is basically a bone lesion, then aligning to the bones is what you want to do. But your PTV is not always a bone lesion, so that's why the more specific
in a soft
answer.
Tissue case now, in a soft tissue case, where if you align to the soft tissue now, like in a sarcoma, and you're aligning to the soft tissue, you might be compromising the bones. So how do you do in such situation?
I mean, Mustefa, you can pitch in, but I think you want to make the PTV align. If you're having discordance, you may want to check that the patient positioning, the angle of their arms or their legs is the same, or else you're really going to run into troubles. So like, if the soft tissue sarcoma is like part of the limb, it's connected to the bone, you also kind of want the bones to align there too.
Yeah.
It's nice if everything aligns.
Yeah, so it comes to positioning, and then another thing too, how much what you call it, margins given, but at the end of the day, you just have to go, what's controlled by the doctor. So if it doesn't, if it doesn't set up right, so we just go back. I tell you, there were days like we have to set up patient 3-4 times to make sure that we get it right the first day. So and then we learn from that how we set them right. So if it doesn't set up, then we have to go back and change the position. Or if there is something, maybe go talk to a doctor. Maybe a patient need a new simulation. So it's all hustle. But if it doesn't set up, we kind of continue with the treatment. You have to address that to the physicist or to the doctor, has to be addressed. Then maybe new simulation needed, especially with sarcoma. What happens is sometimes, because sometimes they will chemo, and after a couple of radiation, the tumor may shrink. Then you have issue when you say, you look at your PTV or any kind of target, you look at it with a CBCT now, it's not lining up. That's why you have to address to the doctor. Again, we want to make sure that, we give them the right dose to the right area. So it's something you need to discuss with the doctor. Sarcoma, like you mentioned, sarcoma. I've seen sarcoma patient within a week, the tumor shrunk big time. So we have to resimulate again. We cannot continue. Like we see that's again, it comes like, we the one who see them every day. Before the doctor sees them. So if you see something changing, we have to talk to the doctor.
Oh yeah.
Does that answer your question?
Yeah, it does. It does.
Thank you.
Thank you.
Thank you. Here we go. So, which of the following concepts is not part of a system approach to error prevention and radiation therapy? How do we correctly allocate blame when an error is made? What could possibly go wrong? What can we do better? Does the solution we are implementing create more opportunity for errors? All right.
Looks like people put A for this one.
Okay. All right. That's the answer is A. So that's the thing we need to avoid. We cannot if you trying to project or accuse people, what's going to happen is people start hiding errors. We need to be open. Talk to make sure that there's like I said when I spoke a couple of weeks ago, we need to have a system that to report error. It should be a learning experience, not like blaming people. But for example, B is not going to be what could possibly go wrong. This is what we have to be proactive instead of reactive. We have to make sure that we have to have a committee, like I said before, committee that include the doctor, the physicist, the symmetry, the therapist, the committee to come up with every possibility what could go wrong to avoid this from happening. And if something happened, what can we do better to fix it? It won't happen next time. And that solution, we are implementing create more opportunity for errors. Again, so the training has to be, studied and making sure that, quality assurances, anything has to be based on quality assurance. So that's why the answer is A. Any question on this one? All right, so that's the last question. Everybody did well. Thank you. Thank you for your answers and for the question too. All right, the last part is going to be, three missions, like missions and RTT team transition to MRT. This it's going to be a short one. Basically, it's, operate the new equipment, hardware and software, align the patient with greater precision accuracy, have a workflow that is high quality control of all levels. We all have different machine, whether it's a Varian or Electa, everything stays the same. Quality assurance, safety. Operate new equipment, the training, the more we learn, the better we learn our machine, either hardware, software. It's focus. When we learn it slow first, make sure that's the right way, then, start building speed. That's the best way to do it. Instead of like to rush and, get confused, just learn. Then make sure that, like I said, that earlier I talked about empathy. If you have that, will force us to learn what we do. We need to have that pride in our job because, like I said, we're dealing with human life. And this is, like I said, this mission, what we do is bigger than us. Totally bigger than us. Sometimes we may have some appointment, we have to go, but machine goes down and we got like 4 or 5 patients left. We need to treat them because, like I said, we don't want them to interrupt that treatment because of what? Repopulation. We don't want that. And some centers, they have only 1 machine in the whole country or 2 machines in the whole country. People are walking from long distance to come in. And, we make sure that we learn how to do QA. Make sure that we learn how to run, the machine, the software. Just give justice to our patient. we're going from here to here, you know, going from Cobalt to Linac, our mission one. So we need to learn, you know, there's a learn curve is high here. New machine, new software, portal imaging, onboard image, OBI, KB, CBCT, respiratory grading. So, you know, just learn that. This is our mission, mission one, know everything. Any center should have a continuing education for everybody, especially for therapists, because like I said before, we are the last line of defense. And the patient, second one is an online outpatient with great accuracy. The right, you know, cradle, mask, and learn how to image matching. Solve position problems. You know, sometimes when the simulation, you know, the doctor come up, you know, okay, I need this. Probably patient has like, you know, a big leg for say sarcoma. And patient can't even, you know, straighten the legs down. How are you going to position patient? Because simulation is the key. Whatever we do in simulation is going to follow the patient the rest of the treatment. So we cannot rush simulation. Make sure that the patient is comfortable and the patient does the cradle or the mask, you know, are done very well. When we make the mask for the brain, for head and neck, make sure let it dry based on how much, you know, the manufacturing is telling. Let's not rush it. Let's not get it up like in 5 minutes. The manufacturer said that 10 minutes minimum. Let's put 10 minutes there. Let's time ourselves. Because, you know, if you take that mask off quick, what's going to happen is it's going to, when it dries, it's going to shrink. It feels like if it's like wet, it's not like, let's say the instructions say 10 minutes. We took off the mask in 5 minutes. It's still wet, still warm, and it shrinks. Then the patient goes to the machine. Guess what? It's going to be a big problem. Now we have to look at a heat gun or something like that to straighten the mask, or patient has to go back and have another simulation. Think about it. Another simulation means other exposure to CT radiation. We spoke a lot last time. So we have to do right the first time. Let's take our time. Make sure, you know, like I said, if patient is comfortable, they're going to be calm. Again, the same thing. Let's say we make a cradle. We do our scout. The cradle is already formed. We take our scout on the CT, doing simulation, and the patient is a little crooked. We go move the patient. We fix the patient, make him straight. But now we go back and scan. The patient looks straight right now. The problem is we didn't remold our our cradle. Next time the patient goes to the machine, they're not going to be straight. They're going to follow that mode. So if that happens, anytime we move our patient, we have to, you know, put air again, reform the cradle again once they get straight. And always try to make sure that patients are straight when we make them, because it's easy to make patients straight on treatment table that makes them crooked, because we have to follow. If the image is crooked, we have to make them crooked to align them. Whatever comes from a simulation is going to follow them the rest of like 10, 15, 20, 30 fraction. Image matching, you know, let's learn how to do, you know, image matching. Like I said last time, if it's big anatomy, let's collimate hours so we can stay quick. Again, you know, we practice a lot again. Again, you know, empathy, that's the topic. It's all comes with the empathy. So, you know, solve position problem, you know, position problem. If you get them right at the simulation, whatever we have in the simulation is going to follow them. So after that, you know, when they come to the table, make sure that, you know, how we're going to fix. But, you know, most of the position problem has to be solved the simulation, because we cannot add much once they come to the table. That's going to change, you know, the whole target. All right, it goes. That wasn't a question. Alignment. All right. Last one is a workflow that has quality controls at all levels. We talked about safety last time. Just, adding up to that, again, I cannot stress enough, it should be 2 therapists at any time. Anytime. This is one way, because sometimes, one person could miss something. So we have to check one another. Timeout, we start our timeout in the room. It goes from there. So, we speak to one another loud. Ask our patient laying down in the room. Before we give them we hand them any kind of, for example, we hand them the stunt. Please give me a name. And therapists talk to one another. What is setup? What's the head holder? Then you come outside, take image. Basically, check each other. Look at your MLCs. Check your parameters. Always. Pilot and co-pilot the whole time. Again, I talk about stop the line. Again, for quality, stop the line. Like I said, it was developed by Toyota, and they have the best cars. They made the best cars, most dependable cars, because of quality assurance policy. Everybody should be empowered to stop the line for the safety of patient. Like I said, remember, we are the last line of defense. We catch a lot of errors. A couple of weeks when I talked about, we catch like 45% of the error called by the therapist. So, but they just build, learn, always safety. Like I said, one word to explain radiation oncology. One word, if I have to use one word, is safety. And today, one word to explain patient care is empathy. All right, this is a reference that I got, the Dr. Reese's the acronym, about the empathy. Thank you for participation in the course. Any question?
Well, thank you so much, Mustefa. It was a wonderful presentation. I continue to learn a lot, and I think our participants also had a really great time. A lot of comments saying, thank you, sir. Thank you, RCC team. Another great session, just like all of the other ones. So really, bringing home the take-home message. And I like the man in the cape. We can all be heroes for our patients.
For sure. For sure. Thank you, everybody.
And so with that, everyone, graduation day, hooray. Cornelius, I see your message. We've loved getting to know you through this course. We hope that we can stay connected. You're part of the RCC family now, and please share the education that you've learned with your colleagues. You're part of this mission too. Emily's going to send information with links to some of those other things that we talked about today. But we're always here, and we look forward to hearing from you. We'll stay in touch, and everyone, thanks for your time today. This concludes the IMRT for RTTs program. Congratulations again.
Congratulations, everybody. Thank you, Dr. Lee. Thank you, sir.
Thank you.
Thank you, everyone.
Thank you. Yeah, have a good one, everybody.
Oh, Mustefa, before you leave,
Thank you.
would you like to turn on your cameras and do one more RCC sign?
Yeah,